my experience with this is that I used to be the neuropsychologist for the inpatient hospital north, south, what was formerly Williams Ward, which is the psychiatric unit. And so oftentimes I was called in to be a participant in the decision-making capacity process or do the decision-making capacity. And so I did have a lot of experience in that through different kinds of complex medical questions and psychiatric questions. And then as a researcher in the ADRC and with my own projects, I have some research-based experience too. I was telling Ashley at the beginning that it skews towards the clinical questions, in part because I think that's the foundation for understanding capacity questions. And then if we get to the end and there's unanswered questions or unaddressed issues around research consent and capacity, I have some additional materials outside of these slides that we can put up and talk about. But since we are an aging center and we are an ADRC, I think part of the point here is that you may be working with individuals who, due to age, may be at higher risk for loss of capacities, either in researching and in the clinical sphere. And that's because we're an aging nation. So here's one good illustration of many that are out there. This one's fairly new to me, which is that people over 65 are going to outnumber people under 18 in just 12 years. And that's going to approach almost a quarter of our population is going to be over age 65. And so with that, there's going to be a projected increase in dementia in the US and other populations that are aging in a similar way. And so here in the US, it's going to be up to 12 million by 2040. I mean, the good news on a proportional level is that prevalence of individuals with dementia is actually in a little bit of a decline due to overall health, but because of the sheer number of people that are moving into those aging brackets, we will still have a higher increasing prevalence of dementia. And that puts people, dementia is a progressive neurological disorder, cognitive and functional impairments increase along with the disorder. So that puts people in some different spaces in their life. And so there's shifts in whether you're able to work, whether you're able to drive, where you should be living, where it's safe for you to live. As something like an Alzheimer's disease progresses, you're going to have increased healthcare expense. Other things happen, like you may rely more on family or caregivers, and those are either informal or formal expenses. And as you sort of begin to progress through this illness and other dementias, it's really a question of your independence changing and your autonomy changing. And what does that mean for what you're allowed to do and the decisions you're allowed to make? And that's where capacity comes in. And so competency and capacity are in the title, but they're different. They're often used interchangeably, but they're not the same principle. So competency is a legal judgment. It's a long process that's determined in a court of law by a judge. There are legal standards that differ by state. And if you're interested, this one right here, NC 35A 1101, is the one that pertains to North Carolina. So that's competency. We don't do that unless you're a judge. Capacity is closer to what we're doing. It is what we're doing. It's the clinical medical judgment, usually in a treatment care context, or it could be in a research context. So that's one important distinction right there. Capacity is what we're talking about. Competency is in the legal sphere. So what do they have in common? They both have this thing in common. You're trying to balance beneficence versus autonomy. So what's important, compassionate, in the best interest of the person versus their ability to make decisions. And you're trying to make those balances in both cases. Another commonality is generally we're presuming that there's a competency or capacity until proved otherwise. In the legal sphere, judging someone incompetent is a pretty high bar. In the medical sphere, capacity could be a high bar or it could be a low bar depending on what the question is. Both of them are multi-component processes. the evaluations of competency and capacity have a lot of the same elements. There's a lot more going on in a legal process, but in terms of what someone like me, a psychologist or physician, might do to weigh in on these questions, we would probably approach them the same way in our sphere. It's just a much bigger sphere when you get the lawyers and the families and all those other advocates and parts involved. So they're interrelated, capacity and consent. So there's an important distinction there. I'd say foremost, when you're doing a medical procedure or a research study, you're really looking for consent. And then the question becomes, does that person have capacity to give consent? And so let me move. I'm just moving some of the faces down because you're getting in the way of my screen. Just give me 1 second. Alrighty. So there's sort of a common law around this for consent. When you're working with a patient or you're doing a research study, you have to give them adequate information about the nature of the proposed treatment, let's say. What are the risks? What are the benefits? What are the alternatives to the proposed therapy or treatment? And that can include no treatment. So that's a lot of information that we're expected to give an individual about treatment. And for research, if you've ever administered an informed consent document, you also know that there's a tremendous amount of information that's put in there to try and assure that there's adequate information before electing to take part in research. The other point is it has to be free from coercion. Research participation is a voluntary process, and you want to make sure that individuals make autonomous decisions if they have decision-making capacity. It's mostly set in terms of its principles, but some states have more specific standards for decision-making capacity than others. But it's important to realize that consent is what you're trying to get, and then that becomes a question of, does that person have the capacity to give consent? So what are the steps in determining capacity? I took this question here from a researcher named Daniel Marson. He is both a psychologist and a lawyer, and he often frames a question like this. He's being asked, or I've been asked this question, does the patient have decision-making capacity? And sort of the cheeky answer to that is, capacity for what? Because there's a lot of different kinds of decision-making capacity. So there's the medical decision-making capacity that might be taking place in the hospital. There are capacities around personal care and independence. There's financial capacity and testamentary capacity, which are sort of related to each other, but they're definitely different. If a financial capacity might be if that person can manage certain aspects of their financial portfolio, let's say their stocks or their retirement. Testamentary is whether someone has the capacity to make a will and say what they want in the will. So I don't know if you ever seen the movie like Knives Out or something like that. Wills can be very, very contentious. So there's testamentary capacity, which is usually a legal situation. There's residential, in a person's ability to live at home versus whether it would be safer and more beneficial for them to be in a sort of a supervised setting. Driving, even nutrition, of course, research consent. So there's multiple decision-making capacities that you may come across. So the medical ones are the most common. And even within medical, there are multiple specific types of medical decisions that may have their own capacities. And I'll try to get into that a little bit or answer questions at the end. Also, I note down here in red that some people, especially in the research realm, would argue that each capacity should have its own independent assessment process. So for instance, Daniel Marson, for instance, I mentioned him earlier, he works with financial capacity and the development of a specific instrument to help assess financial capacity as opposed to other decision-making capacities. Now, there isn't an independent process for all of these, but that's a research ideal for some people. So some things about capacity is they can be lost over time. We talked about this with Alzheimer's disease, and this is This is just a graphic I put up that's sort of anecdotal, sort of hypothetical. They can come sort of in a progression that's potentially predictable. This wouldn't be exact for every individual, but it's sort of modal. Driving may be an early thing to go with cognitive change like AD, financial capacities, especially the investments, again, the retirement, the taxes. People may lose capacity for that, but still be able to go to the store and manage their own pocket money, for instance. There's the medical, there's the testamentary. So some of these things sort of come in an order that might be somewhat predictable. And capacity status is reversible. And so here's an example that you may be aware of if you have any kind of Google or Apple feed on your news with Britney Spears and her conservatorship. Now, most of this took place in a legal arena, but underneath that, there are questions of her ability, her capacity to make certain kinds of decisions, which sort of fed up into a legal process. And that's one of the ways that they're related to each other. And of course, through the legal process, she was able to reverse her conservatorship. In things that are probably a little more relevant and common to us, it can happen in a medical setting. Examples are below Britney there. Sort of adverse reactions to medication, delirium is common. There's often forms of cognitive recovery. So if someone is in acute stage of traumatic brain injury, they may be in a position where their capacity for certain kinds of consent in the medical arena are impaired, but as they improve over time, their capacity could improve as well. So what might have been a lack of capacity at one point in recovery, they might have capacity at a different point. And the important thing to remember there, if you're in this clinical realm, is that you have to constantly be aware of capacity and the possibility that it's changing in order to be fully protective of the rights ethically of your patient. So the steps in determining capacity. These are the 4 things that are listed in my objectives. So take note of them. So the assessment is to really answer these 4 questions. Can an individual clearly, and they're arranged in sort of a hierarchical fashion from the lowest bar to meet at number 1 to the highest bar to meet at number 4. So can they clearly and consistently communicate a choice? That would be maybe a choice about, I might want this treatment versus that treatment, or I might want to take my medication as extended release or not extended release. I'd prefer the side effect profile of this medication to a comparable medication with a slightly different side effect profile. Understanding all the relevant information around a treatment decision. Understanding the consequences of making certain decisions about a treatment, and of course the reason about the treatment decisions. And depending on the complexity of the question, not all of these questions are necessarily relevant. If it's a low risk procedure and it's really about a choice and there's no risk of one choice for the other, and a person can say, I want this versus that, you may not need to go into these other issues. And you don't have to do a capacity evaluation for every question. But when things get complex and there's there's disagreement with the family or the patient or the treatment team, then you may be moving into these situations. But we can't stop and do capacity for every medical question. But as things get more complex, you may move up in complexity and really have to do a pretty deep process of trying to evaluate a person's thinking process around the choices they are articulating. That's redundant. I'm going to skip. So another important thing to know about capacity is that capacity and risk are interrelated. So an old article, but I think a still pretty widely cited article is by James Drain, and it's sort of a sliding scale approach to thinking about capacity. So if things are low risk, high reward for a patient, they're very beneficial. there's not a lot of time spent around capacity. You know, you want to inform people, let them make informed decisions, but you're not as worried about whether they're going to make decisions that are harmful to themselves. Level 1 in DRAIN's sliding scale is, you know, you might be in an acute setting like an ED setting where something's going to be high benefit, low risk, and you have to act quickly. And you may just be able to get assent from that person. So in other words, yes or no. Because of the low risk and the high benefit to that person, it's argued that decision-making capacity assessment is not necessarily the highest part of the process. Level 2 is more common. You might have a chronic medical condition with complex treatment options that have very clear pros and cons to them. And here's where you really want to dig into whether that individual understands the information. When they make a choice, if they make one, that it's well articulated based on an understanding and a reasoning of what's going on around them. So that's really, I think, the common one. There are these levels also when an individual elects not to have treatment and to make that determination would result in death or a serious adverse outcome. And sometimes people make that determination and they're entirely within their capacity to do so. Like, I am not going to take this cancer treatment. I know what's going to happen. I know I will die, but this is my reasoning and this is my choice. And I understand all the risks and benefits that can happen. And sometimes when doing these clinical assessments, I got these referrals that did have the feel of, we really don't think they should make this decision. We want their decision-making capacity assessed. And I sometimes gave them the unhappy feedback of, well, this is not the outcome you want as a physician, and it may not be what most people would want from them, but they clearly have a clear, well-informed reason for doing that. And so we can't use capacity as a tool to get necessarily what we want for the patient. And sometimes that's hard. People sort of get a little muddled up with that. So how do we assess it? Step 1, to me, is an interview. You can't assume lack of capacity based on a diagnosis. So for instance, in this slide lists various kinds of populations and the percent of people who have been diagnosed as having incapacity, a lack of capacity. And so it's sort of useful, I mean, with individuals with mild cognitive impairment, and this is based on a number of different kinds of studies, so we can't really ask what capacity because it varied across studies, but, you know, general decision-making capacity. So mild cognitive impairment, 20% of those individuals lack capacity, but 80% of them do have capacity. And then Alzheimer's disease. Sometimes people get in the tricky situation of thinking that because someone has Alzheimer's disease, they don't have decision-making capacity. And in 50% of the cases, that's not true, depending on the capacity. So keep that in mind. We can't assume lack of capacity if the patient goes against the best advice of the treatment team. That was the level 3 issue that we talked about. But the real goal of the interview is to determine these 4 elements of capacity, which we had here: choice, understanding, appreciation, and reason. Okay, so to me, I think most people agree with me who've written about capacity. The interview is the most important part. In some ways, it's not a different approach than anything else you'd be doing as a physician or a clinician. It's a multi-component process. You know, the interview is important. You need to talk with and understand this person and be in a communicative process with them. But other things are also important. So, you know, putting your physician coat on or hat on or whatever you wear in the clinic. Review of records is always an important piece of information. Behavioral observations. There is cognitive assessment. Some want to be true to this title and get cognition in here. There's also capacity-specific approaches, and then there's collateral information. So, I mean, these are exactly the things I'd be using as a neuropsychologist doing a neuropsychological assessment. It's, I'm sure, what many physicians are doing when they're doing their personal decision-making processes. So it's part and parcel of what you've all been trained to do. There's just sort of different approaches to it. So just a quick note on behavioral observations. So I didn't mention that I'm also the psychologist in employee health. And so something came up recently where we do fitness for duty, which is not the same as decision-making capacity, but it is a determination about whether someone is able to be safe in the workplace for various reasons, which could include cognitive impairment. But oftentimes, if you deem someone fit to work, it could filter up into decision-making capacity questions. But the reason I brought it up is we had a case of an individual who was brought to us for fitness for duty. There was a history of cognitive impairment and some problems in the workplace. They were sent to neuropsychological testing. And because of the cultural differences, it was very challenging for the neuropsychologist to feel that they could render a diagnosis based on testing. And so a lot of the decision was based on the records and the behavioral observations of the individual, not being able to get to appointments on time, making mistakes in the workplace. And those things were really important to understanding whether this individual had the capacities that they needed. And it probably will filter into a more complex question. But that's just one example of how records and behavioral observations are very critical things, and that you don't want to be over reliant on things like testing, because everything has their pros and cons. They're all pieces of the puzzle. To me, sometimes the behavioral observations are the most important part of what I do as a clinician. So moving on to the cognitive assessment. So the pros of having a neuropsychological assessment, a MoCA, an MMSE, something like that, you do get an objective assessment of domains that are relevant to capacity. And so some of those are memory. So memory to me is really important, oftentimes in the understanding component of decision-making capacity. You present all this information to a person. If they have poor memory, they are going to struggle to come up with the ability to hold all that in their mind to make a good decision. It may be going out of their mind as soon as you're presenting it to them. And sometimes the evaluation of memory can really highlight what the weakness is for that person. And it may not even change the decision-making capacity, but it may go in a different direction. You may say, well, this person has very deficient paragraph recall, which means that if you just lay this all out for them, they're not going to remember them. So maybe the approach here to boost their capacity for this important decision is to reframe or augment how you're presenting the information to them. Clarify frequently if they understand, repeat the information, provide them a written documentation that goes with the verbal presentation. So these evaluations, from my perspective, as a neuropsychologist, are not always about the capacity, but how you might improve capacity or what you could do to help the patient with their capacity. Other aspects that are important to decision-making capacity is their attention. You know, if their attention's variable, they may not get through a long explanation, and they may not be able to keep the moving parts in their mind online while they're trying to make a decision. They may forget things that you've said to them that might be important to their decision-making process. That's part of executive functions, your ability to screen out distraction, hold multiple things in your mind, your ability to make abstract decisions and things like that. So those can all be assessed in a neuropsychological evaluation to aid in cognitive capacity assessments. The other thing that's useful is you can have normative information that can say this person is impaired or not compared to the general population, and that's useful information. But impairment, again, is not the same as capacity. And then some tests are diagnostically predictive as well. So you can, with cognitive testing, have a good sense that a person has a cognitive impairment, but that is not the same as diagnosing their capacity. But it is useful to tell you if you need to go further into that process. So the cons of a cognitive assessment, I think probably the most important con is that you need to remember that any cognitive test is only an indirect measurement of those elements of capacity. No cognitive test directly measures understanding, appreciation, choice. So they're pieces of data. The other thing that's important to remember, especially for some of these things like the MoCA or the MMSE, is they can be biased for age, education, and race. So let's say you think 24 is an important cut point for cognitive impairment. That may be true on the majority of the population, but if that individual has less than 12 years of education, or they were educated outside of the mainstream of US educational system, those numbers may not be as valid for them. So you don't want to be over-reliant on a screening test like the MoCA or the MMSE, because you could get false positive errors or false negative errors. A false positive problem might be if you're over-reliant on something like the MoCA score and there's a low MoCA score, you may diagnose that person as impaired when they're not. False negative error. This has come up recently when we're looking at some of the ways that we're diagnosing people in the ADRC. We talked about the false negative error in the NFL with the brain injury determinations and settlements. Race-based norming became an issue, not because of the false positive error that you're over-diagnosing a person, which is what we've always traditionally worried about. The tests would over-diagnose impairment when people were actually normal, because that could be a threat to their autonomy. In the NFL, it was a different question. It was that you were using race-based norms, calling people unimpaired when they actually were suffering impairment, and that puts them at a different kind of risk of not getting an award settlement. So that for any decision that you're making, you want to be thinking about what are the pros and cons of being biased in one direction or the other. I'm going to skip that. So some of the things that you may be familiar with are things that we can talk about in the discussion piece. The MoCA, the MMSE, the SLUMS, various dementia screening instruments that are 5 to 10 minutes long and can get you some limited but useful information potentially. There's helpful neuropsych tests. These aren't necessarily always easily available to you in the hospital setting when you are really only going to have that person with you for a couple of days. What used to be a robust inpatient neuropsych service is not as robust now, as I understand it. I haven't been doing it for 5 or 10 years, but you can still make a neuropsych referral, and I think help with decision-making capacity assessment is a great reason to do it. But things like the Wisconsin card sort, any kind of memory test, all have utility in helping you understand the parameters of the person's cognitive function as they pertain to their decision-making capacity. There's also intelligence testing. That's often very important to the determination of intellectual disabilities. So those are all things that could contribute in varying degrees in a capacity assessment, and they may have varying utility for you depending on what kind of clinical care you provide or practice. You may need to call in a consult, or you may do some of it yourself. So my advice as a neuropsychologist and someone who's done a number of these in the hospital as referral questions is that this cognitive testing, whether it's the more comprehensive thing or if it's a screener, they can provide valuable information about cognitive impairment, but they don't directly answer the questions you need to answer and document in your medical note. They're too inferential. They are pieces of data that can support what you're trying to lay out in your justification of your decision-making capacity question. If you're going to use any of them, you need to understand the limits of these tests. And just remember, they're helpful when testing supports the other elements. It's beautiful when your interview and your behavioral observations and the report of the family all come together. You've got a solid case that helps you feel confident in making a decision-making capacity determination. When they're discordant, it's a lot more work. You really have to get in there and do a lot of deep thought as to why these things don't line up and what it means for decision-making capacity. And that's probably a whole different talk of clinical vignettes and scenarios. Capacity-specific instruments, I think this is an important thing to know about in the multi-component process. So there's lots of them out there. I don't think we have the time or whether it would be useful to go through them all. I have highlighted the MacArthur initiatives for helping do a better job coming to sort of a semi-standardized approach to determining various capacities. As you can see there, they touch on understanding, appreciation, reasoning, and choice. That's probably one of the most popular, I would say one of the most recommended. Another one is the financial capacity instrument, which again highlight because it's a specific capacity assessment for that question. So the questions are geared around financial questions. Another one to think about that I would recommend looking at would be the Aid to Capacity Evaluation, or the ACE. So what are the pros here? Well, they can be helpful as an interview guide. If you do have a standard approach to asking these questions, that can increase your reliability over time and to extent the validity of what you're trying to do. You're doing it the same way, you're asking good questions, you're asking questions that are pretty thorough around the elements you're trying to assess, and you may be using an empirically validated instrument. So those are all pluses. The cons are that they can be very long, and for a simple capacity question, they're probably way more than you'd want to do. They're a lot more burden than you'd want to subject a patient to, except in very complex scenarios. Because they are sort of general, they're not always relevant to your specific medical question. And so you're sort of asking questions that you have to maybe reframe for the patient. You have to change the wording a little bit to make it fit the specific medical question you have, whether it's a cancer treatment question, whether it's a surgical procedure question. The more you modify them to try and be specific, the more you're moving away from something that's sort of standardized. And then there's always this balance between what a researcher would think would be the ideal versus what's you're able to do in a clinical practice. So that's the trade-off always. Though I do think they're helpful, and I do think that it's really worth your time to pull up the MacArthur test. There's one for the hospital setting, there's one for the researcher setting, or the ACE. And even if you don't use it in practice, I think it's a really, really helpful exercise to just read through what they're asking and how they're asking the questions around these four elements. And a lot of people's sort of informal approaches are grounded in these kinds of questions or this kind of approach. And so it may not always be possible or advisable or even, spot on relevant to use these things, but it's a great exercise to read them and understand where they're coming from, because that can just help you with your own interview. So collateral information. So this is useful. Oftentimes family can provide very important information that a patient may be not willing to reveal. Family might feel that this patient is not fit to drive based on their car rides with that person. Or their history of accidents, but maybe the patient's not going to tell you that. They don't want to tell you that they're having accidents. They don't want to lose their license. And so you can get a fresh and maybe a more truthful perspective from family members if you interview them. People may also not have insight into their deficits due to cognitive impairment. I mean, there's always caveats. You need a reliable informant, and you have to remember that individuals who are providing information may be consciously or unconsciously subject to secondary gain. So that's the whole enchilada right there. That to do something very thorough in a complex setting, you really want to walk through as many of these as possible and are available to you. These are high stakes things. Usually, sometimes if it's a simple low risk question, interviews suffice. Review of records might be useful, behavioral observations. But as complexity increases, your need to probably explore and document also increases. Cognitive assessments for assessments for decision-making capacity can be very time-consuming. And so you want to scale it to the difficulty of the question when you can. So there's capacity, consent, and research. I wasn't sure where we were on this. So in brief, I can tell you that the capacity is usually protocol specific, and that's actually IRB language from Duke. You're balancing it against the risk to patients and the benefit to patients, just like you are with other aspects. There's a higher standard for vulnerable populations to obtain consent and determine capacity. There is no real formal approach in the literature around this, though. The Alzheimer's Association has put something out, which I can, after finishing this slide set, put up on the screen, and we can sort of walk through if you want. I also have Duke's guidance from the IRB also on screen that we could walk through if people want to explore that further, or I could just send both out to you after this talk and you could read them that way. But you do have options recommended by the IRB here at Duke. One of them is you could use a formal instrument like the MacArthur for clinical research. That's one option that's presented to you. You could do a cognitive screening instrument, and usually that's recommended if the people are normal and you're just trying to confirm they're normal. Post-content quizzes are actually pretty common in dementia research, where it's a little bit homegrown. And Carolina, I think she's on the call still. She provided me one from the ADRC to look at in preparation for this talk, because I'm usually not involved in that part of the consenting process, but it's essentially a post-content quiz. It's asking you, do you know you can withdraw? Do you understand what would happen if this? Can you tell me the potential risk of X? And it's really, again, a clinical determination, but based on what you're asking them to do in research, you're framing the question so that you can sort of answer those four elements. But it's often pulled together by the researcher and then examined by the IRB to see if it's sufficient to gain capacity. And that's a totally legitimate thing to do. Sometimes, if there's concern about researcher bias, you may ask someone to independently assess those individuals, but they would still do the same things we've been talking about in all these slides. So with about 15 minutes to go, I've got some take-home messages, and then we can open this up to questions. So what I would want you to take home about the entire capacity process is consent is important. The whole thing is about making sure that a patient or a research participant is fully informed of the information about what could happen in a procedure or a research study, so that they can make an informed decision. Another take-home message is capacity is our medical judgment that we've been making in either the research or the clinical setting. And there's four key elements which we've talked about, and those elements are, they're contextually specific based on what the medical issue is. They're dimensional, which means that an individual may be having capacity in one dimension, but maybe not the other. And they're fluid, that individuals can change in their capacity based on what that medical condition is and the course of that condition. And then you really should determine capacity based on multiple sources of information. But those are all hopefully consistent with your broader clinical training. Okay, so that is the end of the slide deck. And I don't see anything in the chat, but, oh, here's one. But I am happy to chat. So what questions do you folks have? And if you want to sort of put your hand up in the chat or just jump in, anything's fine. I see Carolina. Go ahead.
Well, I share with you the quizzes that we have, but this quiz has been established to be used only when the participant has been e-consented virtually. We don't use it all the time when we consent people in person. Should we start doing the quiz to everyone then?
When did you say you're using it? I missed that.
When the participant has been e-consented, done virtually.
Oh,
Online consent. Yeah.
I don't think so. I mean, I think we have a pretty well vetted IRB process, so I don't think we would do anything differently.
Okay.
But you do raise the important question of why you would have that there in e-consent, right? Because the pool of information that's available to the person and their ability to answer questions is not the same as if you were doing them in person, right?
Mm-hmm.
And so that dynamic back and forth and your ability to sort of understand what they know is less than e-consent. So that's a good reason to have a formal assessment process. And a lot of times when there's a homegrown questionnaire, there's conditions written into the IRB as to when you would use it, the suspicion of cognitive impairment. And there might be a test like a MOCA to say whether you may take this sort of stratified step to move into something a little bit more intensive, right? So sometimes it's tiered. You're presuming normal people. It's a normal population, but you think maybe 5% of them may have some cognitive impairment. You may set up a process by detecting the people who may need a bit further assessment, right? So there's a tier or staged process. So you can set it up that way. And that's sort of a version of what we're talking about here.
Okay, thank you.
Yeah. Any other questions?
There's one question in the chat I see. It's
I can say it out loud. I was just curious. I was curious how these kind of homegrown content quizzes, are they typically verbal or written? But it sounds like it might depend if you are only using them in certain situations.
Yeah. Well, would you feel okay putting that up, Carolina? Just with all the caveats that this is really very context specific. It's procedure specific. I can put it up and show it to you.
If you have it available, because it's part of our documents, I don't carry it in my computer.
Is it up now or do I have to reshare? Do you see it?
No.
You have to reshare.
All right, I will reshare. So here's an example. And what I would want you to take from that is you may not use the same specific questions, but you would still be moving along the same types of questions. And I also have one for some of our studies that I do a lot of work with Brenda Plassman, who's a long-standing dementia researcher here, and they're not dissimilar. It's the same kind of approach. And so you do have the basic understanding questions here. So we're looking at, is this person alert? But then you are, that's a basic question. But so the purpose of the study that was just described to you, you're asking the person to relay their understanding of the information that you presented to them. And then you ask them some specific questions to make sure that they understood things like that this is voluntary, right? So did they retain that important part of the IRB? What will happen if they withdraw from the study, right? That's in part assessing a form of coercion, right? You want people to understand that they don't have to stay in the study, or what would happen if they don't stay in the study. I guess the study determines whether you get regular treatment or not, or if regular treatment means, care at Duke, right? There's often that line in an IRB, like if you withdraw from the study, it doesn't affect your care at Duke, even though you may not be able to get the treatment of this particular trial. So you want to make sure that you're assessing understanding of that. Risks and benefits, it's part of weighing that choice. Can they tell you the pros and cons of their decision? So that's a question that gets to that element. alternative to participation. So you can see that not all elements are touched on here, but many of them are. And the purpose of these questions is to really pull out whether the person understands the nature of the study, understands the pros, the cons, the potential risks, sufficient that they can enter into this research in a voluntary, non-coerced way. Does that make sense? So it's the outline of the process, and they would be different based on what's going on in there. But I think this is a pretty good one, and it is a clinical justification that an individual has capacity, unclear, requiring further examination, or lacks capacity. And what's really important to having something like this is that in the absence of some kind of gold standard of determining capacity, you always want to have a documentation of why you did what you did. And that's really the bottom line. This was approved by an IRB. This is what we did. These are what the answers were. This is why we made the decision that we made. And really, anytime you're in a medical setting, your decision-making capacity should have those same elements too. Your note should say, this is how I assessed choice. This is how I assessed, if you stop at choice, that's fine. But if you're going all the way through, this is how I assess choice. This is how I assessed understanding. This is how I assess this. This is how I assess this. Based on this element, I have decided that they have capacity or they don't. You'll always want to document. And so it's all the same process. It's just taking different forms. So that was that one. And so, right. So questions in person when they come in, standard visit. Any other questions that come up about this? Do we have a lot of researchers here? If you do, sort of put a hand up in the chat, and so I can get a sense for that. Mostly clinicians? All right. Are there any other questions? I just throw them out there. But while I've got you, I'll show you this. If you are in the research domain, this is an article that you might want to get. So, I said there's no gold standard necessarily, but there has been some work around cognitive impairment by the Alzheimer's Association. This is an oldish paper, so we'd have to see if it's updated. But this one's good. It does have what I would say are some nice recommendations that would go to an IRB. So that's an important thing to read if that is an interest for you. And I'd say you always want to take a look at this. This is a very helpful document. It's recently updated. This is the IRB's statement on decision-making capacity in adults participating in research studies. So broadly speaking, this would be a useful resource for you. And if you want these, I can send them to Ashley and you can look at them. We didn't have time to get to them, but I think they're important and definitely something you should be reading if you're working in research with people who have potential cognitive impairments that could limit their capacity to take in the information that you're giving them to make a good decision on their behalf. Anything else? I'm happy to field questions as needed.
Hey, Guy, since you're here, I just wanted to ask kind of a question about your thoughts for sort of like the safe, face-saving and humane way when you are screening people out for, say, a study. I feel like you often hit this awkward point where if it's a study that doesn't let somebody come in if they lack capacity, or requires an LAR to come in if you determine that they lack capacity, and you've just determined that, strategies for how sort of in that moment you handle that, then bringing in the LAR or letting the person know that they that they don't qualify. I've seen lots of different things done, including what sometimes almost seems like maybe a little like gentle little white lie of sort of, oh, let me step outside and look at a few things and see, and then come back in, and oh, it turns out you don't meet our eligibility, but kind of trying to not directly link it to, you just didn't answer this set of questions correctly, so now you're excluded.
Yeah, well, I don't know that it's ever not going to be completely awkward at times. I tend to focus back on the fact that, you know, this is a very specific study and it has very specific criteria, and there may be, you know, sort of minor reasons why people may be excluded from the study that don't necessarily pertain to their ability or their capacity. And I think you can say that in very authentic terms sometimes. Like, this is a very specific, studies are very specific, the criteria are very specific, and in this case, some specific things, you know, disallowed you, and we're sorry for that. And then, you know, we've talked about processes where if people have further questions and you're in a CRC role, those should move up to a PI or maybe a group of people and decide, well, we've got this question. This person wants to know what their test on X was, or they want to know what their cognitive status was. And then I think, you know, some IRBs will have that built in, and others may have to make a decision of how you want to communicate that. And so sometimes it can be very specific, but I think it's always best to just say, objectively, this is what the criteria were. They're not personal, but they're built around the study. And so we just, for the, you know, to have a controlled study, we bring in people, and sometimes we have to let participants who are eligible for almost every reason, they can't participate in this one, but how can we maybe help you think about what you can do to further participate or answer the question that brought you here. Sometimes it's what other alternatives can we offer to you. But yeah, I'd blame the IRB, or blame the criteria, and try and be objective about that and depersonalize it.